Welcome, everyone. I'm so glad that you could join us today. My name's Aline Sigler. I'm with Provider Outreach and Education at WPS, and also on the line with me today is Ashley Dakota. She's serving as my co-host today. I appreciate her so much. I want to thank her for helping me behind the scenes, monitoring the chat, adding some special details for you there. And then if anything happens technically, let's say my audio doesn't work or it's becoming staticky or choppy, she's going to cut in and let me know that too. So you're going to hear her voice too, in addition to mine. Now, during our time together today, what we're going to talk about is, first of all, we're going to review some of the coverage criteria that we went over in our first webinar, which was the basics of coverage and billing for skilled nursing facilities and swing bed providers. This is a short series focusing on skilled services. If you're listening to this course as an encore, you can look at our skilled nursing facility playlist on our YouTube channel. Depending on how recently you're looking at this encore, you may also find it on our website in the encore presentations area of our training center. So this overview of the coverage and basics is going to be very brief. So that's just for anybody who might have missed that first session, or maybe you're watching the encore recordings in a different order. And then we're going to go into some additional billing specifics. So we're going to share some of those requirements and those different fields that are required to be filled out on the UB04 claim form or the 837I electronic equivalent. We're going to share some tips to go along with those requirements, and then we'll finish up with some resources. I always like to show you where you can go to, number one, see the requirements in black and white, so you know that I haven't made them up, or additional information on a particular subject. Medicare can be a complex system, and it's a fluid system. The rules change sometimes. So going to those resources where you can actually find those requirements from CMS is going to be so helpful for you. So we're going to start with just a brief recap, like I said, of the coverage criteria. Beneficiaries enrolled in original Medicare have to meet certain coverage criteria and certain conditions to qualify for Part A skilled services. So not just the fact that the patient has been admitted to a nursing home, but that they meet the criteria for Medicare to make coverage and payment. So one of the requirements is a 3-day prior hospitalization. We refer to that as the qualifying hospital stay. There's also a 30-day transfer requirement. Patient has to have skilled days remaining in their benefit period, and they have to require a daily skilled service. This could be skilled nursing care, it could be skilled rehab services, or it could be both. So what I'd like to do is break these down a little bit more and help you better understand what Medicare says those requirements are. So starting with the 3-day prior hospitalization or the qualifying hospital stay, you may hear this called 3 midnights. The patient was at a hospital as an inpatient for a medically necessary stay. Medicare is not going to consider anything that's not medically reasonable and necessary. And that stay is 3 consecutive calendar days, and it can be at 1 or more hospitals. Remember that time spent in observation or in the emergency department doesn't count towards that 3-day stay because the patient isn't an inpatient at that time. When you're counting those 3 consecutive days, count the day of admission, but not the date of discharge. As you're learning more and more about Medicare, you know that Medicare doesn't pay any inpatient facility for the date of discharge. Some Medicare Advantage plans, and by that I mean those Medicare HMOs or managed care plans, some of them don't require a 3-day hospital stay before they make payment. And so that's an exception. If the patient disenrolled or that Medicare Advantage plan goes out of business, there are special billing rules that you'll have to follow, and that is a little bit more in depth than what we're going to go in today, but it is an exception to be aware of, because as you're learning more and you're reading more about this 3-day prior hospitalization, that may come up. And so hopefully just mentioning it will help ring a bell and say, oh yeah, I heard about that. Now let's find out more. The next requirement that I want to mention is the 30-day transfer. Now, this requirement says that the patient has to be transferred to Medicare certified skilled care within 30 days after the hospital discharge. So they have to have that 3-day prior hospitalization, and that 3-day prior hospitalization needs to occur within 30 days of admission to the skilled facility or the skilled swing bed stay. This rule also has some exceptions, and you see them listed here. And it's if both of the situations you see here occur. More than 30 days from hospital discharge might be acceptable. The first one is if the patient's condition makes it inappropriate to start active skilled treatment immediately after discharge. But at the time of discharge, it's predictable that skilled care will be needed, and it will be needed in a predetermined amount of time. So an example of this might be a broken leg. The patient is going to need physical therapy, and the doctor knows that at the time of hospital discharge, but they may be non-weight bearing for a period of, and I'm not a clinician, maybe 4 to 6 weeks. So in 4 to 6 weeks, we know that that patient is going to need skilled physical therapy, but they have to wait to start. That's called one of those exceptions, those medically appropriate exceptions. So I hope that kind of helps illustrate what I mean when we talk about that 30-day transfer, and then what that medically predictable time frame could be that could alter that 30-day requirement. The next coverage requirement is the patient has to have skilled nursing facility benefit days remaining in their benefit period. And I shouldn't say skilled nursing facility benefit days, but skilled nursing benefit days. Each benefit period for a Medicare beneficiary has a total of 100 days for skilled care. And Medicare covers the first 20 days in full after the Part A deductible is satisfied. And then after that, days 21 through 100 have a daily coinsurance amount that the patient or their supplemental insurance is going to be responsible for. I need to pause right here because your slide, depending on when you printed it out, may have a typo. So if your slide, when you look at it, says 81 through 100 in parentheses, just scribble that out and make it 21 through 100. That's my fault. That was a typo, and I looked at this slide deck for so many times and I didn't catch it. So I just wanted to acknowledge that. I apologize for that. So a benefit period begins the day that a patient is admitted to a hospital or a skilled nursing facility as an inpatient. And then a benefit period ends after a period of 60 consecutive days where the patient is either facility free, meaning they're not an inpatient at any facility, or they're in a skilled nursing facility or a swing bed, but at a non-skilled level of care for 60 consecutive days. So after that 60 consecutive days, if they were to be admitted as an inpatient to a hospital, swing bed, or skilled nursing facility, a new benefit period, a new Part A deductible would then begin. So that's just a quick recap of the coverage criteria. Again, we went more in depth on these things in our first installment of this series. But then we want to transition to the real reason that we're here today, and that's billing requirements. Skilled nursing facilities and swing bed hospitals bill Medicare on the CMS 1450, also known as the UB04, and UB stands for Universal Billing. Any electronic equivalent is also acceptable. That would be your 837I, recognizing that the majority of our providers bill claims electronically. Skilled nursing and swing bed claims are required to be billed monthly and in sequential order. The list here that you see here can also trigger the need to drop a bill to Medicare. So when the patient discharges, they leave the skilled nursing facility or the swing bed hospital and they go home or they go somewhere else to another facility type perhaps. When they drop to what Medicare considers a non-skilled level of care. When they have no more days left in their benefit period, we call that benefits exhaust. And if they're enrolled in a Medicare Advantage plan, we require a bill so that Common Working File, which is the patient's master record, can keep track of the days that they've used in their benefit period. So now let's begin looking at the individual billing elements. So what we're going to do is we're going to start at the top of the UB04, the paper claim form, if you've seen that before, that red and pink and white form. And we're just going to go in numerical order by field or form locator number on that UB04. So first up in the top right-hand corner is your type of bill. Now officially it has 4 digits, with the first digit being a 0, but we're going to focus on the 3 digits that you're actually responsible for populating. Since this training is for skilled nursing and swing bed providers, we're going to look at some of the more common ones. And if we look at the first digit indicates the type of facility. A 1 indicates a hospital, and a 2 indicates a skilled nursing facility. The second digit of the type of bill specifies the type of care. 1 is inpatient Part A, 2 is inpatient Part B only, and a 3 indicates an outpatient status. And then lastly, an 8 in this position is used for swing bed. The third digit of the type of bill tells the frequency or where the patient is in their stay. A 0 is considered a no pay. This tells the system and us as your contractor that you're not expecting reimbursement from Medicare on this claim. A 1 indicates the claim is billed from admission through discharge. The entire stay is on 1 claim. A 2 is the first claim in a continuing stay. So it's an interim claim, and it's the first claim. A 3 is a continuing claim, but not the first claim and not the last claim. So depending on how long the patient is in your facility or in that stay, they could have multiple months at this frequency. And then a bill type that ends in a 4 is the discharge claim. So it's not admission through discharge. They may have been in there 1 month, 2 months, 3 months. It just depends on that patient. But when we see a bill type that ends at a 4, we know that the person, that's their last claim. They either went someone else, sadly they passed away, or something like that. So then I want to share just a few common bill types that are used by skilled nursing facilities and swing beds. Whenever you see an X, that just means that that third digit could be replaced by any of those ones that we just talked about. Just some examples. The next field or the form locator that we want to talk about is the statement covers period. That's your from and through dates for the billing period. If this is the patient's first bill, the from date and the admission date will be the same. If it's a continuing claim, the from date will be after the through date of the prior bill. You are required to bill monthly. So it's usually, if the patient's in an extended stay, your from date is usually going to be the first of the month. The through date will be the last day of the billing period, the patient's date of discharge, or their date of death, whichever is the case. The discharge status code, you might even just hear it called a status code or a status disposition. That indicates the status of the patient as of the through date on the claim. This is either the end of the billing cycle or discharge of the facility. This tells the billing system where the patient went and also helps to properly track the patient's benefit periods. Not applying the correct discharge status code can cause issues, such as the examples you see here: underpayment, overpayment, benefit period issues, or accidentally reporting a date of death when the patient is not deceased. It can cause improper payments, which we don't want to see. Errors with claims processing, if the claims can't process in sequential order as necessary. And it can also delay payment to other facilities if, let's say, the patient wasn't formally discharged when they should have been, or that, we haven't talked about this yet, but if their drop to a non-skilled level of care isn't reported properly, that can cause payment issues and errors as well. This is also something that a special review contractor called the Comprehensive Error Rate Testing Contractor assesses errors for on inpatient claims. We've seen it where they come back and tell us to change a discharge status based on their review. And again, it can cause underpayments or overpayments, which is considered an error. So we want to avoid that. So we need to report the status code properly. This slide contains some of those commonly used status codes. Some examples that we see: if you use a 01 to indicate the patient was discharged to home, your claim processes, but we've seen instances where later a home health claim is received, so your claim may be reprocessed to change the 01 to a 06. We've also seen instances where, according to the medical records, the patient was discharged to the hospital, which you see here is a 02, but the status was accidentally keyed on the claim as a 20. So just the letters being transposed can cause some issues, because a 20, as you see, indicates that the patient has died. This is actually going to post a date of death on the patient's record, And then no claims after that date will pay until it's corrected. And that date gets reported to Social Security. So it's not just a matter of correcting it on your claim, correcting it in our system. Social Security may need to get involved as well. And we just want to avoid that if we can. Condition codes. Condition codes identify events related to the bill. So they give the system more information about the patient's stay. We have some examples listed here that you may see on a regular basis, and so we're just making note of them. Of course, we can't list all of them, but a few of them you might see a 04. That acknowledges that the patient is enrolled in a Medicare Advantage plan. You bill the charges to the patient's managed care plan for payment, but then you send us a claim. We call it an encounter claim to Original Medicare to utilize their days and keep track of the patient's benefit period. We're going to talk more about encounter claims or shadow claims in the next installment of this series. If you're listening live, it is next week. We still have room for registration if you want to register. If you're listening to this class as an encore, check out the Skilled Nursing Facility playlist on our YouTube channel and look for special billing procedures with our skilled nursing facilities. And we'll talk about those a little bit more. Another status that you might, or condition code, excuse me, that you might use is a 20. A 20 condition code indicates that the patient requested billing for Medicare determination. We call these demand bills. So in these instances, the facility or the provider has notified the patient or their representative that they don't qualify for a Medicare level of care, but the patient or their representative disagrees and wants Medicare to decide. A 21 condition code is used when billing for a denial notice. When the patient is at a non-covered level of care, or when you're billing for excluded services that Medicare doesn't pay for. Of course, there's way more than this. The last one that we're going to talk about is a 56. When we talked about the 30-day transfer and some of those reasons that the actual admission for skilled care may begin more than 30 days from the qualifying hospital stay, the 56 is the code that tells the system that the medical appropriateness exception is relevant for this patient. So in essence, you're saying, yes, I know the admit date is more than 30 days from the qualifying hospital stay, but it's okay because of this exception. So that 56 is getting our attention and helping to tell the story about that patient. Make sure your medical record has the information that's necessary to back up the use of any of these codes, and for any reviewer that may be comparing what you've billed to what services you've provided, and tell that picture of that patient. Next up is occurrence codes. Occurrence codes indicate when a specific action happened. It's a 2-digit code. It identifies an event or an action, and it includes the date of the event or action. So examples of this might be a 50, which is an assessment reference date for each assessment period on the claim. Now, we're not talking about the assessments or those periodic assessments that you have to do to get the HIPS codes. That's a little more in depth. This is an entry-level course. But that 50 is telling us the assessment reference date for each assessment period on the claim. An 11 occurrence code gives us the date for the onset of symptoms. That's one of the things that's required for rehabilitation therapy. Another one you may see or use often is the 22. That's the date that active care ended. This signifies that last day of skilled care, and that starts that 60-day clock to end that benefit period. Remember, we said 60 consecutive days of not being an inpatient anywhere, or 60 consecutive days at a non-skilled level of care. That 22 is what starts that 60-day clock. So it's very important in telling us what level of care the patient is at, when it started, and so the benefit period can be kept up to date. Puts all those pieces together. We also have occurrence span codes. So these are similar to the occurrence codes, but these, excuse me, identify a specific action or event, but it has a beginning and an ending date associated with it. So an example of this is our qualifying hospital stay. They're indicated with that 70 occurrence span. And then we have the date that they had their hospital stay. A 74 occurrence span specifies a non-covered level of care or dates when a patient was on a leave of absence. Just a couple examples. Value codes. Value codes indicate a specific action and they have an amount associated with it. So it's a 2-digit code identifying the action and a quantity of an amount or dollars and cents. Some examples of value codes are 09. This is where you're going to report the coinsurance that is going to be applied to the claim if the patient has used their 20 full SNF days, skilled days, and now they're in their coinsurance amount. Another example is an A0, which is used for ambulance claims. It has the zip code for the point of pickup, and may not necessarily be used by skilled nursing facilities, but it's just an example of a value code. Another one you may see often is for when Medicare is the secondary payer. There's a code that indicates the type of insurance, like a 12 for working aged, a 43 for disability, a 15, let's say, for workers' compensation. And then there's a dollar amount associated with it that's been paid by the primary insurance. So some examples of value codes. As we're moving down the UB04 claim form, that was kind of the top section, the top 1/3 of that claim, and now we're down kind of in the center part. And so this is where you're reporting your charges. So we're talking about revenue codes. They identify the specific services or procedures that were provided during the billing period. So this can include services from outside providers that were provided under arrangement, let's say, if the service is subject to consolidated billing rules. For skilled nursing facility and swing bed claims that are subject to consolidated billing, and then those services that subject to hospital bundling, if you're a swing bed in a critical access hospital, let's say. Of course, there's many revenue codes. A couple examples shown on your slide here. Revenue code 0022, which includes coding from those periodic assessments that you have to do if you're a skilled nursing facility or a swing bed that's paid under the prospective payment system. This is a key component in that payment system. A 42X reports physical therapy. There's also a revenue code 18X to report a leave of absence. So for those days when the patient is not present at midnight. So just some examples there. Next we have, if you're going to the right on that UBO4 claim form, we have the columns for HCPCS, HIPS codes, and rates. So the Healthcare Common Procedure Coding System codes, HCPCS, describe the service that's identified by the revenue code category. You have to have these if it's required on your bill for line item billing. I use the example of physical therapy. A 22X inpatient Part B claim requires line item billing, but a 21X inpatient Part A claim does not. And this is because of how the reimbursement is calculated. Inpatient claims need an accommodation rate for room and board. It's a required element. For claims paid under the SNF prospective payment system, the HIPS code, Health Insurance Prospective Payment System code, is required. So this combines the case mix and the assessment indicator. Again, that's more than what we're getting into in this course, but that is required because that is what tells the system what level of care the patient was receiving for how many days, and then calculating the payment. So it might seem like some random letters and numbers, but it does give Medicare lots of information, like I said, about the patient, the payment, and it is necessary for proper claims processing. Continuing along with the format of the UBO4, going across the page, the next thing that comes up is the service date. This is also required for line item date of service billing. It includes your 22X and your 23X claims. That's the type of bill. Format your date as shown here. So you have month, month, day, day, year, year. Moving on. Units of service. These can be a couple different things. It's the number of room and board or accommodation days. If your patient was out of the facility, this is also the number of leave of absence days. For a given assessment, this could be the number of days covered by that assessment period. It could also be the number of times a service or procedure was performed according to the description for the HCPCS code. So this could be 1 unit per encounter, such as a therapy evaluation. Other codes might be reported in 15-minute increments. I'm thinking of some of those therapy services, or maybe drugs that have directions for a specific amount that equals 1 unit of service. So in all of this, it's important to know that correct coding according to the regulations is necessary, not just for proper billing, but for proper reimbursement. You're going to want to add the ICD-10 code for the principal diagnosis. This is the condition that is established to be chiefly responsible for this admission. You're also going to code the other conditions which coexist or develop during the patient's stay. Medicare beneficiaries may have multiple comorbidities that should all be captured on the claim depending on the patient and depending on the situation. So these are some of those required elements on that UBO4 that you're going to learn about, you're going to need, and that are going to be coming to you if you're the biller from that clinical staff, whether that is your director of nursing, whether that is your assessment coordinator, your MDS coordinator, whoever that's coming all into the billing office to be put on the claim to Medicare. Our next topic that we're going to talk about just briefly is consolidated billing. We have a separate series of webinars that we do periodically focused on consolidated billing. But we briefly want to mention these items that have to be included on your claim, and you may not have actually provided. Under consolidated billing, the skilled provider is responsible for the overall plan of care for the patient, and so is responsible for furnishing everything that patient or that resident needs during their stay. So you're providing everything directly, or you're making arrangements with an outside provider to furnish those items and services that you cannot furnish. The skilled nursing facility or the swing bed provider has to submit all claims for all services that the patient receives during that stay, except, there's that word again, exception is for items and services specifically excluded from consolidated billing by CMS. I mentioned that we have a separate series of webinars focusing on consolidated billing. So look at our live events page, register for upcoming events, or look for that SNF consolidated billing playlist on our YouTube channel. You can find the link to that playlist and other consolidated billing resources in the Learn More section of our slide deck, and we'll take a look at that in just a few minutes. I want to share just a few tips and reminders with you. Some of you may be just beginning to learn about Medicare, may not have been encountering these situations yet. Some of you may be pros, you may be old hat, and this is just a review for you. But again, these are things that you can refer back to as needed. So we established that bills must be submitted monthly and in sequential order. So I want to remind you to wait for the prior month's bill to completely finish processing before sending the next one. So if, let's see, we're in May. So if April's bill hasn't fully finished processing yet, hold off on sending May's bill until that happens, even if the patient has discharged. And in doing that, it's just going to prevent those claims from bumping into each other, especially if one is hung up with a billing error or possibly medical review. You just want to wait for that one to finish processing. Likewise, if the patient has exhausted benefits, let the 21X process before sending the 22X or the 23X, because maybe the patient has exhausted their benefits or gone to a non-skilled level of care. There are still Part B services you can bill for, but let that inpatient bill completely finish before sending that Part B bill, whichever is the case there. Just helps your claims through the system, prevents them from getting hung up, from bumping into each other. Also remember when counting your prior hospital stay that the date of discharge doesn't count, and neither does observation or emergency room claims. So make sure you have those 3 midnights. Remember that a patient who is not present at midnight, we call that midnight census, is considered on a leave of absence, and that must be reported as a non-covered day for your facility. And we're going to talk more about the specifics on actually how to code that on your claim in our future training. As I mentioned, if you're listening to this live, it's coming up next week. If you're listening to this as an encore, look on our encore presentations page and search for special billing situations. That should bring that course up for you, because I realize people might be watching these in a different order. So what else have we got for you? The HIPS code. The HIPS rate code appearing on your claim has to match the assessment that's transmitted to and accepted by the state where the facility operates. We call that the state repository. So when the assessment is done, if it's not done by you, Most facilities have an MDS coordinator or something similar that is actually doing the assessments, completing them, transmitting them to the state, and then reporting that information to the billing office. Somehow, I realize that might look different to each facility, but what's on the claim has to match what's in the repository, or you're going to get an error. If an update or a correction is necessary, make sure that information gets passed on to the billing office. Be sure to use the correct discharge status code on your claim. We talked about how the wrong code can affect the patient's benefit period, can affect payment to your facility, and hold up future claims. Along those same lines, then, make sure that you discharge the patient. We have seen instances where a claim won't process, and we discover that a previous stay, maybe even at another facility, still had the patient status of 30 on their last claim. Maybe they weren't expecting the patient to discharge, but they did. But this can affect the patient's master record, and also because that benefit period will continue on in error. So if the patient isn't discharged properly and we don't see that break in care or that break in stay, it can affect future claims at your facility, other facilities, and ultimately it's affecting the patient because they may have services and charges that they're responsible for that they shouldn't be. I put together some resources where you can go to learn more about the topics that we talked about today during this session. And so this first slide, I've kind of combined them here, contains items pertaining to consolidated billing. So there's a fact sheet where you can read more about the major categories of exclusion, things that CMS has said are maybe beyond the scope of what a skilled nursing facility should be responsible for. There's also a SNF Consolidated Billing webpage on the CMS website. Has a lot of good information, gives you some other links to additional material. The third bullet takes you to a CMS web-based training. This is a great interactive online course. And then the last bullet here is a link to the Consolidated Billing playlist on our YouTube channel. I mentioned that a couple times. This slide then contains resources for skilled nursing facility and swing bed resources here. If you downloaded a copy of the slide deck, you have the live links here. If you're listening to this class as an encore, look in the description of the video. All the links will be listed there. So I'm just going to run down this list as well. 100-2 is the benefit policy manual. And chapter 8 is specific to skilled care and coverage. So this is going to be where you're going to find information about the qualifying hospital stay, the 30-day transfer, the definition of a skilled service, and so on. And then the Medicare Claims Processing Manual, 100-4, Chapter 6 is where we go into the guidance for billing, for consolidated billing, submitting bills in sequential order, those types of things. The third resource here takes you to the Skilled Nursing Facilities Center or webpage on the CMS website. So that's going to be where you're going to go for important messages and links to a lot of other information. The last two resources here are Medicare Learning Network products put out and published by CMS. First one is a SNF educational tool. And then the second is a fact sheet all about the 3-day stay. So you can check that out in your own time there. So now is the time in our program where we're going to address questions. I received a few during the registration process, so I'll talk about those first, thanks to those of you who sent those in, and then we'll see what we've got in chat. First question, what are the appropriate room and board revenue codes for swing bed claims? Well, there's a variety of revenue codes for room and board based on the situation. I can't tell you which one to use. We're actually prohibited from giving coding advice and things like that. But you can refer to the National Uniform Billing Committee, the NUBC website for details. And they'll give you a definition of those different codes. I'll have Ashley place a link in the chat for you where you can go out there. The NUBC is actually the one who technically owns and maintains information about UBO4 claim form. And so all those different form locators that we've been talking about, you can find information out there. Now, depending on how far you want to go into that, there may be subscriptions or charges associated with some information that is outside of the WPS and CMS realm. I just want you to know where you can go to get those details. Next question. If a patient has a Medicare Advantage plan, do we have to bill the Advantage plan and get a denial before billing the skilled nursing facility? Now, this question could be answered in a couple different ways, depending on the provider type, but I'll do my best here. First of all, Medicare Advantage is a replacement to traditional Medicare. So it's not a primary-secondary situation. For inpatient Part A claims, you'll bill a claim to the Medicare Advantage plan for payment, and then an informational only or encounter claim to traditional Medicare to keep the patient's benefit period up to date. And you can file these simultaneously if you choose to. We are going to discuss this in next week's class, focused on those special billing situations. If this question came in from a non-SNF provider and pertains to consolidated billing, if the service is subject to consolidated billing, you send the charge to the skilled nursing facility for reimbursement under arrangement and not to the Medicare Advantage plan. That would be considered double billing. Next question we received during registration. I called a SNF and the business office stated they are not responsible for the service because the patient had Medicaid on the date of service. How is this handled? It sounds like this is related to consolidated billing, and the rules pertain regardless of Medicaid entitlement. If the service is considered part of consolidated billing, you bill the charge to the skilled nursing facility, and they are required to reimburse you and include that charge on their Part A claim to Medicare. And the last question that was submitted, if a drug code is not on the fee schedule for the year and quarter, does that mean it is SNF billable or not? If a code is not listed on the CMS SNF annual update files, it's likely included in the bundled payment and not excluded from a consolidated billing. So this means that the skilled nursing facility is responsible for billing and the service is not separately billable to Part B. As far as drugs go, only specific high-cost services, mainly chemotherapy drugs, their administration, radioisotopes, and specialized services are excluded and allowed to be billed directly to Part B. Of course, there's more to it than that, but you'll want to check out those consolidated billing resources that I've provided to learn more about that, because that is one of those categories. And then you're going to have to drill down to the specific code for that drug. So this course isn't intended to be consolidated billing education, so that's why we didn't go into depth on that subject. So that's about all I can tell you there. Now I'm going to check in with Ashley. I want to see what questions you have related to today's topic. Remember, this is not designed to be consolidated billing training. It's designed to be an entry-level course. If you have anything that's claim specific, that's going to have to go to customer service, where they can actually access the claim in the system, look at it with you, and provide guidance. If we run out of time and we still have questions left, I will respond to those and you will have another opportunity to send those in. Ashley, do we have any questions in the chat?
Aline, we had just a couple questions come in. The first one says, we are a CAW. What would be an example of where a patient would be discharged to when they are waiting to qualify for a swing bed? Example, fracture with no weight bearing.
That would be an example. So if the patient, the doctor ordered skilled care, but it's medically predictable that they'll need that skilled care in a predetermined amount of time, they may be in a skilled care, but at a non-skilled level of care. And so what I was talking about was how to show that on your claim. So that could be an example where they can't be discharged to home. They still need an inpatient level of care, but not yet. If I need to look into that more and do a little bit more research to provide a better answer, I can sure do that.
All right, we just had one other question, which is, what would be an example of a patient out of the CAW over midnight?
It depends. It depends on what the patient needs. Now, at a critical access hospital, for those of you that don't know, those are those smaller rural hospitals. The patient may need a service that can't be provided at the critical access hospital. So you may have to transfer them to maybe a city hospital, a bigger hospital for more specialized care. And they go for that service and you fully expect them to be back before midnight, but they're not. Maybe they have to be observed for a time before the patient can be transferred back. So if that patient isn't back to the original critical access swing bed facility by midnight, then you may have a leave of absence situation. I hope that helps to clarify that.
All right, we did have one more question come in, Aline, if we have time for one more.
Yeah, let's go.
All right, this one says, you may have answered this already, but if a patient has a Medicare HMO as their primary insurance, would it be appropriate to bill an IME claim for a swing bed claim, or would the IME claim only be for acute IPPS hospitals?
Now, I could be wrong, but I believe that IME, that medical education, is just for inpatient Part A and not swing bed, I believe. And I can take a look at that question just to clarify and make sure that I understand it properly. And if I need to give clarification or provide more information, I can definitely do that. Thanks for those questions, everybody. Great. We're going to move on in the sake of time here. I don't want to keep you. So in a couple minutes, you're going to receive a survey. You're going to be asked to do a survey about this course to tell us what you liked, what we could do better, and also suggest topics for future education. You have a few options depending on whatever your preference is. You can use the link that Ashley's going to place in the chat, or when you exit this webinar, you're going to be asked to go to an external site. And that external site is the CMS page for the survey. And that message is going to look similar, not exactly like, but similar to what you see here on the screen. It's going to have the triangle, it's going to have a continue button, and if you hit that continue, it's just going to launch that survey for you. If you're listening to this course as an encore, you're going to get a box that links you to the survey, and it's going to look like this screenshot right here with the hand and the stars. There's also going to be a link in the description of the video. So, there's a number of different ways that you can take the survey. You only have to take it once. Just a couple more tidbits of information for you. In a few minutes, you're going to get an email from us. It's going to thank you for attending. It also has a link to the survey. But what else it has is that it contains your certificate of achievement if you need to turn it in for consideration of continuing education units. It has your name, it has your contact hours, the date, the name of this course. And so I don't want you to look at it, think it's spam, and delete it. Because if that's something you need, you want to save it, maybe save it as a PDF and upload it to your accrediting body. I just want to make you aware of it. If you don't see it in the next couple minutes, check your junk or your spam in your email. Make sure to add the WebEx email address to your safe sender list, because again, these are going to be important if you need them for contact hours. If you think of a question later, you have 1 week from today to submit a follow-up question. Send them to our same education mailbox. Put today's date, something about SNF and swing bed billing in the subject line, and then those will get funneled right to me and I can respond. For the questions that I had today that I need to research and provide more information on, I will send them to everyone in attendance. On behalf of myself, Ashley, all of us in provider outreach and education, I want to thank you for your time and your attention today. We hope to have you join us for future education, and we look forward to your survey feedback today. Thank you. You may now disconnect. Have a great rest of your day, everybody.